Your post-op CABG patient is failing to wean from cardiopulmonary bypass. The heart muscle is stunned, exhausted, and barely squeezing. You've got your pressure and your inotropes maxed out, but their cardiac output is still in the basement. The heart needs a bailout. It desperately needs to rest, but it still has to pump enough blood to keep your brain and organs alive. How do you do both? You bring in mechanical assist and enter the intra-aortic balloon pump, or IABP for short.
Welcome to RES 220, Hemodynamics for Respiratory Therapy.
By the end of this video, you can visualize exactly how an intra-aortic balloon pump physically unloads a failing heart, how it alters hemodynamic on the monitor, and how to spot catastrophic placement errors before they happen. Let's talk real estate. You slide this catheter up the femoral artery and park it right in the descending aorta. But placement is incredibly precise. The tip of the balloon has to sit just distal to the left subclavian artery, and the bottom of the balloon must remain superior to the renal arteries. Why? Think about the physiology of what happens if it migrates. If the balloon slips too high, it blocks the left subclavian. You lose perfusion to the left arm and potentially the brain. If it slips too low, it blocks the renal arteries. The kidneys instantly starve. Next, let's talk ammunition. What exactly are we pumping into this balloon? It's not room air, and it's definitely not oxygen. We are using pure helium. Why helium? Two critical reasons based entirely on physics and safety. First, density. Helium is extremely light. It moves incredibly fast, and if your patient's heart rate shoots up to 120 or 130 beats per minute, that gas has to shuttle in and out of the balloon in fractions of a second to keep up. Air is too heavy. It would lag behind the cardiac cycle. Second, safety. Helium is highly soluble in the human body. It dissolves rapidly. If you pumped room air into the aorta and the balloon tore, you'd cause a massive lethal gas embolism. Helium dramatically reduces that risk. Your clinical tip here: look at your gas lines. If you ever see flecks of dry brown blood or bright red blood in the translucent gas tubing coming from the patient, the balloon is ruptured. Stop pumping immediately. If you don't, you'll pump helium straight into their bloodstream and drag blood right back into your expensive console. So, why are we putting a balloon in the aorta anyway? The primary goal is counterpulsation. We want to increase oxygen supply to the heart muscle and decrease the heart's oxygen demand. And here's how that happens on the monitor. Look at the A-line waveform. During diastole, the heart relaxes, and that is when the balloon inflates. This takes up space in the aorta and physically pushes the volume of blood backward, right into the root of the aorta, force feeding the coronary arteries. You just drastically increase the O2 supply to the heart. Right before the heart is about to squeeze, right before systole, the balloon rapidly deflates. This sudden deflation creates an instant vacuum effect in the aorta. It drops the afterload. The left ventricle now has to do a fraction of the work to eject blood forward. You just decreased O2 demand and simultaneously increased cardiac output. Because of that better forward flow, you'll also see secondary wins like a bump in urinary output and a better systemic perfusion. The trap here is timing. If your console is miscalibrated and the balloon inflates during systole, the left ventricle tries to eject blood against a fully inflated balloon. You are pumping against a brick wall. That spikes oxygen demand and can blow out the ventricle. Who gets this therapy anyway? You'll see this deployed in two main scenarios. severe cardiogenic shock, like a massive heart attack where the heart or the pump is failing, or in the OR when a patient can't be weaned from the bypass machine. It's a temporary bridge to recovery or surgery. But you absolutely cannot use an IABP if the patient has an aortic aneurysm. Think about the physics. You have a weakened, bulging aorta, and you're violently inflating a rigid balloon inside 80 times a minute. That balloon will literally tear the aorta apart, and the patient will bleed to death internally in seconds. It's also contraindicated in end-stage heart disease where there is no bridge to a transplant. If you remember one thing from this lecture, the IABP is a precision tool. It saves a failing heart by manipulating physics, inflating during diastole to feed the coronary arteries, and deflating during systole to reduce the workload. But if it moves an inch, or if the timing is off by a fraction of a second, your lifeline becomes a lethal weapon. Watch your pulses, watch your urine output, respect the waveform, and never ignore blood in the tubing.